everyone. Happy Monday. My name is Shalaya Yazdi. I'm a public health practitioner and a Master's of Medical Health Science student at Touro University. Since the pandemic began, people around the world face a shift in their normal routines, and we all had to make our adjustments, but we also need to keep in mind the importance of maintaining our health and managing whatever conditions we may have, preventing future conditions from coming on. And that's why we're here today to raise awareness about various conditions that can be impacted by diabetes and the various conditions that diabetes can present us with. So thank you so much for coming. I'd like to introduce you to Dr. Jay Shubrook. Dr. Shubrook is going to teach us a lot about our kidneys health, and we're going to ask for you to join us in the conversation through the Q&A. So please type in any questions or comments that you have into the Q&A function, and we will be so happy to address them. So thank you so much, Dr. Shubrook, for coming today.
It's my pleasure, and it's nice to be on this side of the mic.
I'm excited to open up the conversation and learn more about kidney health. I also wanted to mention that this will be recorded and posted onto our website. So if you'd like to share this in the future with your family and friends or anyone in the community that you think would benefit from this conversation, then you will be able to access it. It'll be posted on YouTube. So Dr. Shubrook, I think let's just dive into it. What do you say?
That sounds good, right? This is National Kidney Month. And so not all of our organs get a month, but this is a month focused on kidney health, and what a great time for us to talk about such an important topic.
Absolutely, thank you. And it is in the spirit of National Kidney Month. We just had Kidney Day last Thursday on the 11th, and I think it's so important to just learn more about who does get kidney disease, who's at risk for it.
Yeah, so I think this is really important. So I remember when I was in school, I was challenged by one of my professors to say, you can live without your heart, but you can't live without your kidneys. And I thought, well, that doesn't make any sense. But it's important to know that the kidney is a really important organ that allows you to keep all the things in your body that are supposed to stay there and get rid of things out of your body that aren't supposed to be there. And so we all will have some changes with our kidneys with aging, but the conditions that are most closely tied to kidney disease are diabetes and high blood pressure. And so something like 80% of people who have kidney disease have either background diabetes or high blood pressure. So those are the most common conditions tied to kidney disease.
Oh, and how will someone know if they have any kidney problems?
Yeah, and I think this is probably maybe the most important thing I could share tonight, is that like many things, as it relates to diabetes at least, you wouldn't possibly know right away early. The most common symptoms are none. And so this is really where it's so important to get your blood tests done, to get checked for kidney disease. And again, there are a couple different ways you can get checked for kidney disease. One is through a blood test looking at your creatinine. The other is for a urine test looking for protein, because one, your body should be able to get rid of creatinine, so that number should be low in the blood. And two, you should not be leaking protein into your urine. So if you have protein in your urine, that could be a sign that you have kidney disease. So screening tests are the most important way, not waiting for bubbles in your urine or feeling bad, because those things are not specific and they really don't tell you enough. So the most important thing you can do is get screened.
Thank you. That's really important information. And I was also wondering, well, what if my kidneys were affected from hypertension or diabetes mellitus? In that case, should I go and ask my doctor or my healthcare provider, can you please screen me for it? Or what would your recommendations be?
So yes, and I think as an active consumer, if you have high blood pressure, if you have diabetes of any type, or if you've had frequent infections or anything like that, you should want to understand what your kidney function is. And function is both by how well does it filter and how well does it keep things in. So it's normal and expected that at least once a year, you get these tests if you have high blood pressure or diabetes to check to see if you have kidney disease. And again, I don't expect you to have any symptoms, so you do have to rely on these tests to see if you have that.
We do have a question here in the chat, and that is the damage to the kidneys permanent even if it is minor?
Well, thank you for the question. That's an important question. It really depends on the nature of what the test results are. So, you know, for example, if I were to do a long run or a long bike ride and not drink any water, my kidney numbers might look really bad if you checked my blood test at the end of that run. But that's not true kidney damage, because as soon as I drink water again, it'll be better. So I think it's important to know that the tests have to one, be done in conditions where we expect them to be normal. And then two, if it's a bump in the creatinine, it might be fully reversible. We talk about chronic kidney disease when these numbers have been high for at least 3 months. So a single blood test or even a single urine test is not enough to say that the damage is permanent.
Thank you, Dr. Shubrook, and thank you to our audience member who asked this question. We have a few more coming in now, and that is, what is creatinine exactly, and why does our body want to get rid of it?
Oh, okay. So that's a good question, and maybe I misspoke. So creatinine is a breakdown of protein in our bodies. So creatinine is a piece of that, and the normal turnover in muscle is normal for the body. And so you're turning over the pieces or amino acids all the time, and you get rid of some creatinine on a regular basis, and it's the creatinine left in your body that is important. And we don't want the build up in your body, because that means your kidney is not getting rid of the extra creatinine. So you only want what you need to build good muscles. And so it's not that your body wants to get rid of it, it wants to maintain a healthy level.
Thank you so much. And we have another question in our chat, and I think this is actually going to open up our next topic. For example, patients that have been diagnosed with diabetes and have been on dialysis. Can we talk a little bit more about that, please?
Sure. Well, I think the first thing I want to say is that the majority of patients with diabetes don't ever progress to chronic stage renal disease, which means you need some kind of renal replacement. And dialysis is one of those. So I'm happy to talk about dialysis, but I know a lot of people are really afraid that as soon as they get diabetes, they're going to get kidney disease. And actually, it's only about 30% will have measurable kidney disease if you're able to maintain and manage your diabetes. So I think it's actually good news for let people know that one, if you can screen for it, and two, you can prevent most kidney disease. Now we can jump ahead and say, let's say that you've had kidney disease for a long time, and you're at the point now where your kidneys can no longer keep up with getting rid of the things it should and holding on to things it shouldn't. And so now the kidney is starting to leak protein and the creatinine is building up. If you start to develop symptoms of what we call uremia, and it's a terrible feeling for anyone who's had it, they feel tired or sluggish. Some people say they feel like there's been a film all over their skin that they have to kind of walk through. So if you start to develop uremia, we really need to help the kidney to do the job. And dialysis is one of the ways to do that. And there's a couple different forms of dialysis. And so absolutely, it's important that we know that that's one of the options, but it is something that only a small number of people need. Now, people get dialysis because they want to feel better. Dialysis doesn't necessarily make you live longer, but hopefully it gives you a better quality of life so that you're not feeling bad from uremia. Did I answer your question? I know that was a long answer.
That was excellent. Thank you so much.
Okay.
Also, to go off of the same topic, it's what are the certain types of diets that are needed for people who are on dialysis but also are diagnosed with hypertension and diabetes?
Yeah, so we've learned a lot, and you know the Kidney International guidelines were recently updated just the end of last year. So if there's anyone that wants to kind of hear the guidelines, they actually have a guideline set for patients and a guideline set for providers. So you could actually look up KDIGO guidelines and type in chronic kidney disease, and you could actually see the patient first facing ones versus the provider. I've lost my question. What was my question?
It was, what are the certain types of
Oh,
dietary needs for
yeah, thank
dialysis?
you. Yeah, so with diet, it used to be that we put people on a very specific diet when they had chronic kidney disease, because we were thinking that if you lost protein in the urine, that you shouldn't have protein because protein is bad for your body. Well, we've learned that that's not true. We want you to have a healthy, well-rounded, mostly plant-based diet throughout the spectrum of kidney disease. And it used to be that patients who had diabetes and who had high blood pressure and who had kidney disease, we'd say, oh, you got to be like a breatharian, right? You can only breathe air because you can't have cholesterol, you can't have carbs, and you can't have protein. Well, we know that that's no longer the case. We want you to eat, we want you to build your strength, and as much as you can, try to avoid processed foods. And then if you do have advanced renal disease where you have the buildup of phosphate, there will be some restrictions in your diet to prevent you from having too much phosphate. But that's usually only for those people who have really advanced kidney disease and need renal replacement like dialysis.
Are there also restrictions regarding the amount of water patients should intake, or about the amount of sodium that patients should take in?
Yeah, great questions. So there's nothing special, as I know, regarding the sodium, other than whatever you would do for diabetes and high blood pressure. We've learned that not everybody is salt sensitive. And so for some people, the amount of salt is a big deal. For other people, that's not so the case. So the salt intake will be largely driven by what does that do to your blood pressure. In terms of, what's the other nutrient you asked about?
It was salt and water.
Okay, and water. So in terms of water, it really depends on whether you're making urine or not. Anyone that's had dialysis, they talk about their dry weight, which is the weight at the end of dialysis. And so sometimes there'll be some recommendations for water intake for those patients, but the great majority, there is not a limitation to water from kidney disease.
Thank you so much. That is very helpful.
Yeah.
And we have another question from our chat. What is the life expectancy of dialysis patients?
Yeah, so remember that people with dialysis have advanced kidney disease, and it really depends a lot on what was the cause of the chronic kidney disease. So it's, certainly there's a limited life expectancy if you're in dialysis. So I don't want to beat around the bush there, but how you got there has a lot to do with it and what your plan is. And so if you could do anything to change that life expectancy, since I can't give you a single number because that number is different depending upon how you got there, is to have very early intervention from a kidney doctor to prevent the progression so it takes longer. And so if we can take the progression from stage 1 to stage 5 kidney disease and make that longer, that also lengthens life. And dialysis itself doesn't lengthen life, it just improves quality of life. And so again, making sure you're taking care of those other problems will also help you to live longer. So I wish I could give you a single number. And I would say that some people will actually talk about 5 years, but that number is highly variable. And I don't want people to get the sense that there's just a single number to that, because it isn't.
Thank you, Dr. Shubrook. Now, say someone has a family member that has diabetes and is also on dialysis, what should the family members look out for?
Yeah, and anyone that has a family member who has dialysis can really appreciate how much work it is. It's a lot of work. And just for the sake of being complete, there are 3 forms of renal replacement. One of them is hemodialysis, which is where you have dialysis through the arteries of the body. And so you go to a dialysis center 3 to 4 times a week. The other is peritoneal dialysis, where you get exchanges of fluid through your belly. That's often done at home at night. And then there's renal transplant. So I'm assuming the question is related to one of those first two types of dialysis. So it is really important that people with chronic kidney disease on dialysis weigh themselves regularly, because there is a certain weight that we're shooting for. And if that weight starts to change, they're more likely to be fluid overloaded or fluid depleted. The second thing is to just be really patient. You know, most people who go into dialysis, they don't feel good. And it's hard to be happy. It's hard to kind of be energetic when you don't feel good. And hopefully dialysis helps them to feel better. And so just know that there may be days, not to any person's fault of their own, that they don't feel as good and they may not want to interact as much.
Thank you, Dr. Shubrook. I'd also like to let our audience know, if you joined in a little bit later after I mentioned this earlier, about any chat question, any questions you have, please enter them into the chat or the Q&A function, and we'll be very happy to answer your questions for you. Dr. Shubrook, in the meantime, can I ask you to teach us a little bit more about any kidney advice that you have? What else should patients look out for if they've been diagnosed with chronic conditions such as hypertension or diabetes?
Yeah, so I think first, you know, we always talk about know your numbers. So I think that if you have kidney disease in any other condition, it's kind of good to know where you're at, and it's good to track it over time. I teach the medical students and residents all the time that we want to pay attention very early in kidney disease and try to slow that part down. We don't want to wait till the house is burning, right? We want to try to prevent the fire early on. So I think knowing your numbers early on really makes a difference. I also want to say that we've made a lot of progress preventing the progression of diabetes-related complications. And so I really want to give a hopeful message that if you identify that you have diabetes early, you identify that you have high blood pressure early, those again being the two most common conditions, and you treat them, and you're aware of your risk of complications or reducing your risk of complications, that really can change everything for you. And so I think, you know, get your sugar under control if you can, get your blood pressure under control if you can. And then certainly we've now learned that there are many medications that we give patients, not because of the primary problem, but to protect their kidneys. And I know that could be that's somewhat hard for patients. Like, why do I have to take a medicine when it's preventing something I don't have? And again, that is a bitter pill to swallow, I guess you could say. But it is one that really does make a difference. And because the complications can be severe of diabetes and hypertension, it's usually worth doing. And please work with your healthcare provider to make sure that, one, you're on getting screened, and two, if you're not tolerating some of these medicines, talk to them about it.
Thank you, Dr. Shubrook. We have another question in the chat. Does kidney disease affect the brain and memory?
Wow. So I have only a partial answer to that. I wish I had a complete answer. There is no doubt that kidney disease is a marker of cardiovascular disease. In fact, what's starting to emerge is that if you have protein in your urine, that might be one of the biggest risk factors for having other cardiovascular disease. So, you know, like small strokes or TIA. So definitely that could have an effect. The other thing is that people who have advanced kidney disease, when you get uremic, it can definitely change the way you think. It can change your memory. It can even change your mood. So absolutely, when someone becomes uremic, if you suddenly see a behavior change, you see a memory change, they really should go in and get some blood work done, because absolutely you can see changes from that.
Thank you. And that was a great question. Another follow-up question is, can CBD or THC affect kidney patients?
I will have to look that up. I'm not aware of any immediate risk from that, but I would like to give a thoughtful answer. So for whoever asked that, please reach out to us, and I'll get you a follow-up answer, because I'd want to give you an accurate answer.
Thank you. Another question is, If there is kidney disease in my family, am I at higher risk for developing kidney disease?
So thank you for your question. So it depends on the cause. So if it's high blood pressure or diabetes, which are the most common causes, the answer is yes, because those things tend to run in families. But there's other conditions such as polycystic kidney disease that very strongly runs through families. So if someone in your family has kidney disease, it's good to know why. And that alone is enough of a reason to get screened if you have those risk factors for that primary condition. So the short answer is yes.
Thank you so much.
Yeah.
And does anyone else in our audience have any questions they'd like to ask?
I see some in the Q&A. So one of the questions is, why are certain ethnicities more prone to getting chronic kidney disease? And that's absolutely true. So, and that's a complicated answer. And I would say, I'll try to start very wide and then I'll try to come narrow. And we're still learning. So absolutely, we see a higher burden of chronic kidney disease in African-American populations, Native American populations, and some Latino populations. And we can say that there are maybe genetic risks, but I would also say that there are structural risks. I think that access to care, access to testing, having a healthcare team you can trust, making sure you have the support to get all those things done, do contribute. So I know that for many of my patients, maybe they have access to blood testing, maybe they have access to healthcare, maybe they don't. And if you've been disrespected or you've not felt that you could trust your healthcare team, you're probably less likely to go to them. And so I know that has been a real issue in the healthcare field in the United States, to make sure that we have an openness and an accessibility to all of our community members, because that is very important. Now, above and beyond that, it does seem that, and particularly African Americans, can progress through kidney disease a bit quicker, and we have even individual numbers. And we know that baseline creatinine is generally higher if there's more muscle mass, and baseline creatinine is higher if you're male gender, and your baseline creatinine is higher if you're African American. So that's why it's so important to know your baseline, because then you would know if your baseline changes. Because if I am, a short 5 foot, 7 foot person, and I'm next to a 6 foot person, the odds are that the person who's 6 foot has more muscle mass, and they're going to have a higher baseline creatinine. So we want to know what that baseline is and not overreact to it. But we also want to know when it changes. And so knowing your numbers, going back to that, knowing your baseline is really important, and addressing those things and getting one, access to screening, and two, working with a provider you can trust and doing the things you can do to prevent. Because I also know I've had many patients say, well, I got diabetes now, so I'm going to go on dialysis. And that's actually not always true. I mean, the majority of people don't go on dialysis. I think it's like 10% of people with diabetes will ever go on and need dialysis. So it's a small number, and so you really can prevent it.
Okay, wow. That's incredibly informative. Thank you, Dr. Shubrook. And another follow-up question regarding dialysis is, how long can patients go without dialysis?
Yeah, so and again, another great question. This is a very informed audience. It again depends on how many exchanges are done with dialysis, what the reason for dialysis is, and what's the stability. So for example, if someone comes in with a very severe illness, let's just say COVID, and they go into renal failure, they might need emergency dialysis right then and there. They can't wait 4 hours. However, there are some people who go into dialysis that might need less frequent dialysis and might be able to miss a day and not necessarily be hurt so much. There is a movement in medicine that's just relatively recent where people who go to end-stage renal disease don't necessarily go on to dialysis unless they feel bad. So how you feel has a lot to do with it. Now, I'm not encouraging people to skip dialysis if they don't feel bad, but fewer people are going on dialysis now because the main driver should be helping you to feel better. So the person who, how long can they go without dialysis might be determined on how long they can feel okay. Because again, then every time they do dialysis, they're getting rid of all those waste products and getting the right salts and things back in their diet or back in their blood.
And another question we have is it normal to feel tired after dialysis? How do patients typically feel, for example, if they're on dialysis?
Yeah, so that's a great question. Again, it depends on how many exchanges were done that day. Many patients do feel very tired after dialysis. Imagine that you go in and you have it's not all your blood, it feels like all your blood's been taken out and then put back in. And so many patients are dehydrated after dialysis and they just feel tired. And so that's a pretty common experience to go home and need to sleep. It's also pretty common not to feel very hungry. Because it is a big shift in the body. And if you feel dramatically worse after dialysis, it is worthwhile to talk to your dialysis team and say, hey, I've really felt lightheaded or dizzy after this, because it might mean they have to recalculate your dry weight and have to recalculate how many exchanges they're going to do.
Thank you so much, Dr. Shubrook. We have more questions in the chat, and that's now shifting toward kidney disease in terms of prevention. So let's say a patient is diagnosed with kidney disease. Would exercise help slow down the progression of it?
So good question. So that the answer is indirectly yes. What happens is we used to think that you shouldn't exercise if you have kidney disease, but we've now learned that absolutely exercise is helpful for all stages of kidney disease. And exercise can help improve blood pressure, can improve glucose control. So it also improves the drivers of things that relate to kidney disease. So, do what you're capable of doing. It's not time to start running if you've never run before, but physical activity can be very helpful in the management of both kidney disease and the management of weight.
And could that be physical activity such as walking?
Absolutely. Or even pedaling, doing leg lifts in your chair, or doing, kind of air presses in the air as well. So do what, was within your capacity.
And I believe last fall we had some more information about physical activity within the home, and I can pull up that and put it into our chat for anyone who would like to take a look at the video. Maya Ramsey and Roberta Flannel had an excellent Q&A session about physical activity. Physical activity in the house or anywhere that's accessible. And we have another question in the chat. Is hepatitis a common issue with kidney disease patients?
A good question. So not universally. So there are some people who have developed hepatitis first and end up developing kidney disease second. I'm not aware of kidney disease being a driver for hepatitis unless there's been something like a traumatic injury and a blood transfusion, or some kind of intervention where hepatitis was obtained through an IV mechanism. So I think that's less common than the other way around. More common is hepatitis leading to kidney disease.
Okay, thank you, Dr. Shubrook.
Yeah.
And there's another question about medications and kidney disease. Are there certain medications that could predispose patients to kidney disease?
Yeah, so you're all doing great. One of the things that I would say is two of the most common medicines taken in the United States that can lead to kidney disease are Tylenol and ibuprofen. And so we know that both of those medications have an effect on the liver, mostly for Tylenol, and ibuprofen mostly for the kidney, but they can affect either. And there's both, you could take too much at once and hurt yourself, or you could take too much over a lifetime. So I would really encourage you to only take those medications when you need them and not preventively. Because if you take too much of them over time, there is a cumulative effect. And there is not like you take 4 tablets and twice in a month. It's people who take it regularly, people with bad arthritis, people with chronic pain. There is a cumulative effect from that. So that's another person that really should have some screening to look at their kidney function. Most other medications are very unique. So there are medicines that help protect the heart. There's medicines that help the heart but hurt the kidney. There's some antibiotics that can hurt the kidney. But usually that discussion is held at the time that you're given that medicine, and you're really looking at risks and benefits, because sometimes those antibiotics can save your life. And so we'll take the chance that that might hurt your kidney, even temporarily. You didn't ask this, but I'll say there's medicines that help the kidney as well. So, we know that there's some blood pressure medicines such as ACE inhibitors and ARBs that actually have been shown to help the kidney. There's medicines for diabetes, such as the SGLT2s like Jardiance or Farxiga or Invokana or Steglatro. They have actually been shown not only to help the diabetes, but help the kidney. And then there's medicines like the GLP-1s, such as Victoza or Ozempic or Trulicity, that have been shown not only to help diabetes, but also help the kidney. So sometimes you're going to see medicines that have 2 things that help you more than just the diabetes itself. And so sometimes we're using these medicines. In fact, the American Diabetes Association recommends that if you have evidence of kidney disease, you could consider using one of these medicines, even if your sugar is normal.
That is very interesting. Speaking of the medications, and I was wondering if you could tell us a little bit more about the insulin versus oral medications for patients with diabetes. I mean, with patients with diabetes and around dialysis.
Yeah. So many patients who have advanced kidney disease and now need dialysis actually need way less medications. And so I think it's important for people to know that if yourself or your family member has kidney disease and you see people taking medications off, it's usually for that patient's safety, because the kidney is slowed down enough that the medicine sits around longer, and they're really at risk for low blood sugar. So you'll see that we might take medicines like sulfonylureas off, or sometimes even insulin off, and use medicines that aren't processed by the kidney. If we are going to use insulin, we usually will use either shorter acting insulin or just enough insulin to kind of help reach the goal, because we don't necessarily want the person to drop low. And so you will see a reduction in medications typically as it relates to diabetes, maybe not blood pressure though. And you might see a loosened glucose target for someone with dialysis, mostly because we want to give you the most benefit with the least risk.
Excellent, thank you. We had a follow-up question regarding dietary intake restrictions, and this question is in our chat. Why shouldn't dialysis patients eat potatoes, chocolate, dairy, or guacamole?
Yeah, so what can happen is the kidney phosphates can build up in the body when you have chronic kidney disease, and that's a little bit harder to process through dialysis. And so it really depends on everyone's individual lab tests. When we're looking at magnesium, we're looking at phosphates. And so if you start to build up phosphates, you might see very specific recommendations, like you've just heard, saying, please avoid these foods so that we don't get too much phosphate in the blood. So that's the goal, is to stop the buildup of byproducts.
Thank you. That was a great question. Another question we have in our Q&A is it normal for a patient who has a high hemoglobin around 16.8 and who's on dialysis and has chronic kidney disease?
Yeah, so most people with chronic kidney disease, and so maybe I should back up there. Remember, I told you the kidney keeps things in that should stay in and lets things out that should go out. But the kidney also has very important roles in the building of blood and the kidney also has very important roles in managing hormones in the body and blood pressure. So it does a lot of different things. So the great majority of people with chronic kidney disease are going to be anemic. They're going to have low blood counts because the hormone that comes from the kidney to tell your bones to make blood slows down. So it's pretty unusual. And so the answer to the question is it's not normal to have a hemoglobin of 16 because most of the time it would be much lower. The one exception to that is if you have a primary blood disorder that's causing kidney disease. So something like a multiple myeloma or myelodysplastic disease, you might be building too much of a certain blood type, and that might be contributing to kidney problems. But most of the time you don't see that. And unlike most causes of anemia, when you have chronic kidney disease, we're not going to try to get your blood count all the way back to normal. We've actually learned that bringing your blood up to about 80% of normal, like a hemoglobin around 11, is the best benefit for safety with the least risk. Higher levels of hemoglobin actually means that you're a little higher risk for things like blood clots and heart disease. So you'll see that we purposely don't try to shoot for normal, and we definitely don't shoot for high.
Okay, thank you. We have another follow-up question regarding the medications. Does amlodipine do anything to help besides lowering blood pressure?
So good question. When you see the blood pressure medications used, sometimes they're used to lower blood pressure. Sometimes they're used to relax the blood vessel, and sometimes they're used for the kidney. Amlodipine is most commonly used. The main reason it's being used is to reduce blood pressure. It does help to distribute fluid a little bit, but its main focus, unlike ACE inhibitors, would be to lower blood pressure. So its main focus.
Thank you very much. We have another question in the chat, and that is, are dietary oxalates a consideration in kidney disease?
Sure. So when you look at the type of kidney disease the person has and what sort of things they're building up, absolutely we look at that, because one of the things that could occur, for example, is kidney stones. And calcium oxalate is one of the forms of kidney stones. So that would be one of the things that a nephrologist, more often than any other kind of physician, would be measuring and monitoring and trying to modify diet as well. I've mentioned it like in that very specific food list would be another example where there would be specific changes to the dietary intake.
What are dietary oxalates specifically?
Oh, I don't know if I can give a simple answer to that. That's also one I'll type back in because I want to make sure that I give one that is scientifically accurate. So thank you.
Okay. Well, thank you so much, Dr. Shubrook. Is there any additional advice that you can relay to our amazing audience here today regarding kidney health and Kidney Month now, how to raise awareness about it, or what kind of discussion points we can open up with our friends and family and encourage everyone to get screened for kidney conditions?
Yes. So I think first and most of all, know your numbers. Please go out, and if you have risk for kidney disease, get checked. Second, kidney disease is largely preventable, and we can do a lot early on. And if we do the work early on, you may never have chronic kidney disease. Even if you do get to the point where you progress to chronic kidney disease, there's still a lot of things we can do to help you have a better quality of life. And ultimately, if we can reduce the number of people by a lot, we could get more people to kidney transplants. That really gives you the longest benefit, even more so than dialysis. But of course, we have so few people that have the ability to get kidneys that that's our challenge. Right now, there are more people with chronic kidney disease than there are people that can donate kidneys. And so while I can't stop someone that already has it, I think we can do a lot to prevent people from getting it, and know that high blood pressure and diabetes are the biggest contributing factors. And if you know your baseline and you can track from there, you can really know where you stand and protect your kidneys.
Thank you. And another question. I was wondering if you can tell us more about patients who've had one or more kidney stones. Does that increase their risk of kidney disease in the future?
Good question. So kidney stones themselves rarely contribute to chronic kidney disease unless you really get lots of downstream obstructing stones. Remember, we have two kidneys. And so if you have a kidney stone here, it doesn't necessarily affect this kidney. So to me, that's a very small player in the chronic kidney disease. But one thing that I think I would really recommend our patients to think about is that if you have had kidney disease, or excuse me, if you have had kidney stones, make sure at some point we know what type of stone it is. Because if it's a uric acid stone versus a calcium oxalate stone, we're going to give you different advice about the way that you can change your diet to prevent that. So, so that again, smaller contributor to chronic kidney disease, but a big contributor to pain and suffering. So please make sure you catch a stone so we can give you specific dietary advice.
Wonderful. Thank you so much. Another question I had is I've grown up drinking lots of water, but I know people who don't like to drink water, say less than 16 ounces per day. So how does that contribute to kidney disease?
Yeah, so imagine you drive your car without a lot of oil. Things just get gunked up and they just don't work as well. I would really encourage people that, assuming you have safe drinking water, which, sadly has become an issue, but assuming you have safe drinking water keeps your body lubricated, keeps things moving, and allows you to get rid of toxins. And so I would really encourage people that, there is not a set value. We often default to 8 glasses of water. But, I like to drink water to just get my urine just to the point where it's clear. It doesn't have to be all clear, but it's, if I'm drinking and my urine is not clear, then I'm probably getting just a little bit dehydrated. And so I think that that's one thing we can do, and it helps all parts of our body. I don't know about you, but I just feel better when I'm properly hydrated.
Absolutely. Yes, it's essential. And it's a very good point to bring up about accessibility. Say a patient or anyone doesn't have access to clean drinking water. What are the next best alternatives?
Wow. So that really takes us to a new level. So first of all, most cities provide water reports. So you can actually see what your water is like. And the good news is that we really do as a country try to provide clean water for our populations. But that being said, if you have to buy water, buy water. If you can get it filtered, a lot of homes will filter water if they can afford that. That's a really tough problem because again, there's a lot of structural components to that. Where do you live? Is it safe to get someplace to get water? I would encourage most people though that if you can get your water report, you don't need to spend extra money buying bottled water. For most of us, we can drink our water, and that's not true all over the world, but it is true most of the United States.
Thank you, Dr. Shubrook.
Yeah.
I was hoping to ask an additional question from our audience to see, I was just going to ask if anybody else had any questions, but we got one right away. Thank you so much. Why do the dialysis technicians say you must stick to 32 ounces per day? Is excessive water damaging to the kidneys?
Yeah, so again, this is a little bit individualized to someone's individual fluid status and how many exchanges they're doing. So if you don't make urine, and that's a really key component to that, and you keep drinking a lot of water, the water can't leave, which means they have to do more of an exchange at dialysis. So that those restrictions probably would only relate to someone who is on dialysis who is not making any urine, because there is no way to get rid of that extra volume. And even that is individualized to the patient and how many exchanges they need to do to get rid of the toxins. So it's fluid is one thing they're getting rid of, but the other is the toxins. And so they only want to take off enough fluid to get the toxins that they need to get off.
Thank you so much. These are excellent questions from our audience. Thank you all for asking them. Dr. Shubrook, do you have additional insight about kidney conditions and, let's say, other conditions such as, like you mentioned earlier, hypertension or diabetes, but other chronic conditions as well, that patients can be aware that kidney disease is a risk, they're at risk for kidney disease?
Yeah, so what I would say is that for those people who have high blood pressure or diabetes, there are three main levels of complications. Diabetes, it's your neuropathy or your feet, it's nephropathy or your kidneys, and it's retinopathy or your eyes. So if you have diabetes, all three of those things should be checked. If you have high blood pressure, you typically don't get a lot of neuropathy, but you can still have problems with your eyes and your kidneys. So I would encourage anybody with diabetes to get all three of those things screened, and anyone that's got high blood pressure to get those two things screened. And they typically go in parallel. So for example, if somebody has nephropathy or kidney disease, I expect them to also have a certain amount of eye disease. And when those two things don't match, I might be looking for other causes than the diabetes itself. Same thing with high blood pressure. If those two things don't match, then I'd be thinking about that. And I will put a plug out for future meetings as we wrap up, that we will be talking about protecting your vision in the near future. We have a session focused on protecting your feet and neuropathy. So these are really great questions, and we hope that you'll join us in the future when we talk about some of these other topics. And it might be one of the dream team, or it might be an eye specialist or a kidney specialist or a nerve specialist joining us.
Well, thank you so much, Dr. Shubrook. We have one more question in the chat. What is considered too high of blood pressure for the kidneys?
Yeah, so at a very general level, when it gets above 140 and it gets above 90, that's too high. Now that's the general population. People who have chronic kidney disease, remember that I told you early on, it does the filtering, but it also controls the hormones. It's normal to develop higher blood pressures with advanced kidney disease. And so you'll see that we will tolerate a little bit higher blood pressure, because it'll be very hard to get down, because when the kidney's not filtering, the hormones that feed the kidney say, hey, raise the blood pressure so we get enough pressure through the kidney. And so that will be largely individualized to the person. And you'll see that we also try to minimize the pulse pressure. So one of the things that scares me a lot as a provider is when that top number is really high and that bottom number is really low. So let's say someone's got a blood pressure of 180/80. Well, clearly that top number is too high, but that bottom number is normal. That doesn't make me feel better, because if I give them a medicine to lower the blood pressure, I'm going to lower both the top number and the bottom number. And then maybe their blood pressure is 140/40. Well, now they feel horrible, right? Because they don't have enough blood pressure between heartbeats, and they might feel lightheaded or dizzy. And they might even not perfuse their kidney as well. So you'll see that we try to individualize that blood pressure once someone has advanced kidney disease, to one, prevent them from having symptoms, but two, lower enough to protect their kidney.
Thank you, Dr. Shubrook.
Thank you. We hope everybody's enjoyed the night.
If there's any additional questions, please let us know. We will be happy to answer them. We're really grateful to you all for coming in, and for any of our viewers in the future watching the recording, thank you so much. We hope that we were able to cover all your questions, and would invite you to visit our website to review any previous recordings or see our upcoming schedule, which will be posted soon. But like Dr. Shubrook said, there'll be retinopathy and neuropathy and a few more discussions that are coming up. So thank you all for coming again. Please fill out the survey feedback form so we can learn more about what you would like to see in the future.
Thank you. Thanks,
Have a good
Shalaya.
day. Thank you.